What a cute puppy picture.
All right, Mercedes, are you seeing Julie at all in the waiting room?
So I'm going to go ahead and start the webinar, and then I'll be able to see who's in the waiting room.
Okay, sounds good. There we go. All right, so we are just going to allow everybody to join at this point. If you give us a few minutes, we will get started. All right, so it looks like we have folks joining us. We'll give it a few more minutes and we will get started.
For anyone who is joining us today, please note that we are live streaming to YouTube. So if you would like to reference this material later down the road, or you'd like to share with a friend, you can find this discussion streamed and maintained at the College of Health Solutions YouTube page. So you can do a quick Google search, YouTube and the College of Health Solutions, and you will have clear and easy access, and it is available for the public.
All right, so we are at 2:05. We are going to get started with this panel. The first thing I would like to do is welcome everybody. We are so excited to bring this panel and this topic to you as a part of our ongoing health disparities panel discussion series that we've been doing for over a year. We have quite a few panels and different topics and different experts that we have brought in from both the Edson College of Nursing and Health Innovation and the College of Health Solutions to discuss some important topics that are related to healthcare, and the disparities that different groups of people experience within the systems. So today, our topic is women's health and the disparities that women kind of face in healthcare and their own health. So we're excited to bring some of our amazing faculty and personal healthcare experts in to discuss with you today. As we mentioned earlier, this is going to be live streamed through YouTube and will be available after this recording is done, or after this live stream is done, for later viewing privileges if you would like to take a look at the recording later on. We do also have all of the other panels that we've done in this series on the YouTube channel as well, if you would like to check that out at any point. So to start, my name is Riley Milner. I'm a student support specialist with the Edson College of Nursing and Health Innovations engagement team. I'm super excited to be here today and be our moderator for today, and to introduce some of our amazing faculty that we have here, as well as some of the staff members that you will see kind of interacting maybe in the chat or answering some of the questions along the way that you may have. We do have the Q&A feature open at this time. So if you have any questions that you would like to ask our panelists, I will be sure to embed those in our discussion and try to get you some answers as we go. We will be doing a follow-up outreach to all of the attendees after this event with a list of resources and some references to some of the things that we are bringing up today, because we do realize that women's health and the health disparities within women's healthcare is quite a large topic. So there's a lot to talk about when it comes to this, and we recognize that. So if you have any specific things that you pick out of this discussion that you're interested in learning more about, that resource will be available to you. So before we start, I do want to do a land acknowledgement and just let you all know that Arizona State University's Tempe campus does sit on the ancestral homelands of the Acamel O'odham, or the Pima, and the Peeposh Maricopa peoples, just as a recognition of where our campuses are located and who has been on this land longer than we have. So to kick us off, we have our discussion moderator, who is me. I'm Riley with Edson College. We do have Mercedes Amador here as well. She is the Director of Student Services with the College of Health Solutions. So you may see her in the chat. I see she's already posted in there, so thank you. She's our tech guru for today. And then we have our three amazing panelists with us as well. So I'm going to do a quick read through of their bios and introduce them. So they should all be pinned up and you should be able to see them here soon. But our first panelist that we have is going to be Dr. Julie Sullivan Deathridge. Julie has received her BA in English from Arcadia University, has a Master's of Journalism from Temple University, and a PhD in International Development with a concentration in public health from Tulane University. Prior to ASU, she worked for 10 years as president and CEO of a nonprofit that worked in over 20 sub-Saharan African countries on community-based health and education reform, including the prevention of maternal transmission and HIV/AIDS and health literacy. She teaches courses with the BHP program in community and public health, healthcare ethics, and culture and health. She has served as a thesis director for the Barrett Honors College and a faculty advisor for GLOBE and TIMI Global Health. Dr. Sullivan Deathridge has always wanted to share insights based on her work in difficult areas around the world with students who also aspire to work with those vulnerable populations, either in clinical settings or in a public health setting. When she finished her doctorate, the plan was for her to pursue a postdoc within academia, but as a divorced mother of three, she was required to return to her full-time job at the nonprofit. Things fortunately have come full circle. Everything that she has done prior to teaching at ASU has led her to be prepared to enjoy and be challenged by the most exhilarating work of her life, which is teaching our aspiring youth here at ASU. She continues to challenge herself through cross-cultural research in concert with Edson College faculty. Our second panelist that we have here today is Farzana Sarder. Farzana is a certified physician's assistant with a background in neurology and critical care medicine. She is an ASU alumnus with a bachelor's in biochemistry, and she has earned her master's in physician assistant studies from Midwestern University. Farzana is currently a full-time instructor at ASU, primarily teaching HCR 240, which is human pathophysiology. Her motivation to become a PA came from her enjoyment of learning and her desire to be able to use her learned knowledge in a meaningful way to help other people. She later joined academia for the same reason, in addition to her love for teaching. So thank you, Farzana. And our third panelist that we have today is Sandra Woodruff. So Sandra received her Master of Science in Public Health from the University of Colorado. Her undergraduate degree is in recreation with an emphasis on recreation for special populations. Ms. Woodruff is a board certified patient advocate and former ski instructor for disabled skiers. She is in her 4th year teaching at the Edson College of Nursing and Health Innovation, where she arrived after having spent most of her professional career involved in quality improvement and health education programs. Ms. Woodruff's career highlights include serving as a coordinator and subject matter expert for the compilation and sharing of tribal and locally designed activities for diabetes prevention programs, a national initiative of the Tribal Leaders Diabetes Program that included over 60 tribal Indian health services and urban Indian health centers. Over 15 years of experience related to Medicare oversight of kidney dialysis centers, culminating in serving for 5 years as the executive director of one of the 18 agencies in the nation tasked with quality improvement and complaint investigation efforts related to the dialysis centers. And then 2 years in the Peace Corps in Eastern Europe, specifically in Moldova, teaching health education in the local school and strengthening the community's efforts to encourage girls to stay active and healthy through sports and other activities. So Ms. Woodruff comes from a family of teachers and always said she would never become one, but she credits her young Peace Corps colleagues with awakening her desire to work with young adults and share her passion for community health and health education. Her experience teaching middle schoolers in a foreign language country with helping her get over her fear of standing up in front of a classroom filled with students. So our 3 amazing healthcare experts and faculty members come from a broad variety of backgrounds. And I'm so excited that they're here today to discuss this topic with you, as well as their own experiences, their research, anything and everything to offer about this topic in what they have. So with that, we will go ahead and get started with the actual panel portion now that I've done most of the talking. I do want to highlight that I understand this is quite a broad topic. It was brought to our attention because this month is Women's History Month. So we wanted to do something special for this month in recognition and acknowledgement that this is quite a large issue that we hear about quite often. And I know for myself, it's something that I've experienced in the healthcare system as a woman, going into those spaces and not always feeling as comfortable or feeling some of those biases for and towards women and like their healthcare experiences when I go into those spaces. So I'm looking forward to learning more about that today, getting to share some of that knowledge with you all, and hopefully find some new paths that we can go down as far as exploration of this topic. So my very first question that I have for our panelists, and it is up to whoever wants to start. Maybe we go in the order that I introduced you all in. Is what is it about today's topic that excites you and that you find to be important and that has kind of motivated you to be a part of this panel? So Julie, would you like to start?
Sure. And I guess I'm going to just start off by saying thank you so much, Riley, to you and everybody for inviting us onto this panel. The topic is very interesting to me. I mean, it is essential that we discuss healthcare disparities with respect to women and minorities and vulnerable populations. What excites me is the opportunity to articulate, in my view, what we are not doing, which is clearly we know what we know. We know that there are these inequities. You know, we know, for instance, that Healthy People 2030 has separated the social determinants into 5 domains: economic stability, education access, healthcare access, neighborhood and built environment, and social context. But guess what? Those are very similar to the same social determinants that they threw out for 2020. And I believe that when we discuss healthcare disparities, we need to start stopping chasing the tail of the dog, but actually moving forward. That's what excites me about the topic. And so with respect to women and healthcare disparities, we know, for instance, that women who live in segregated residential communities face a higher prevalence of chronic disease. That's borne out by data. The NIH and CDC peer-reviewed articles show that. We know, for example, that Native American women and Black women have higher maternal mortality rates. These are things that we clearly know, and those statistics have been trotted out year after year. What we're not doing, in my humble view, is doing a more granular, in-depth analysis of why that is still acceptable to us in the United States, given these wide healthcare disparities. So back to your question, why it's important to me is that it's well and good to understand that there are differences in prevalence of disease between racial and ethnic groups, as well as people with disabilities. There are gender differences, sexual orientation, age, all of those things count. But what we're not doing is at a granular level, understanding and answering questions like, okay, why is it okay for the United States to accept segregated areas where certain types of people live in food deserts, where they're more likely to face barriers and inaccess to healthcare insurance? Why is that true? Because we know that according to the US Census Bureau in 2020, 28 million people did not have health insurance, many of whom who couldn't qualify for Medicaid. So I believe that we talk about health disparities, let's not just trot out the stats that we already know. What are we going to do about it? What are we going to do to change the tone and the timbre of what is the topic of this discussion? So that's why I'm excited. And so I'll take myself off the floor.
Amazing, thank you. Farzana, what is it that excites you about today?
Yeah, so hi everyone, welcome again. My name is Farzana and I am a physician assistant. And one thing that you will see when you start to learn medicine, especially medicine from a Western perspective, it has developed around the idea that your patient is a very cookie cutter patient. And all of Western medicine is shaped around a white male patient. And when you learn about all of these different diseases and disorders, it still has that basic assumption of the white male patient. But that's so not true, right? Just when you look at the patient population that we are responsible for caring for, a lot of our patients aren't white males. Yeah, some of them are, but a great percentage of them are not. 50% of them are women, and a great majority of them are also minorities. And we have to understand that the way that different diseases present, the way that medications interact with people's bodies changes depending on who that person is, changes based on whether or not they're male or female, changes based on their different ethnic backgrounds. And so learning just about the white male patient, what heart attacks look like, what pulmonary embolisms look like in that one particular patient is not good enough. It's never been good enough, but especially now in today's age, we are starting to recognize more and more that it is not good enough. And as healthcare providers, we have to seek more knowledge and learn how to take care of all of our patients. And I'll talk about that more as we continue our panel discussion.
Thank you. And Sandra, what is it that excites you about this topic today?
Oh, okay. Thank you. And thanks again for inviting me to this. Yeah, I was really excited to be able to talk about this because moving on from I feel like I almost have, Julie gave me, or Dr. Sullivan Deathridge gave me.
Julie, please, oh God, don't make me feel old.
Just gave me a perfect,
even though I am, but
Hey, anyway, you gave me a perfect segue into what excites me about it is my favorite class to teach is communication for healthcare professionals. And that how knowing this as a student can help you pay attention to it more as we're moving forward and start learning to do something about it. There's really some great bias research out there to talk about how we have so much intrinsic bias that we don't recognize as healthcare providers, that we're not that we aren't even trying to fix it because we don't know that we have it. And so the fact that we can be educating people to be learning more about what it is and how to look for it and how to check yourself is really exciting to me. And that I found a couple things that just talked about. Cedars-Sinai put out something that talks about the fact that we need to understand that women's healthcare is 30 years behind men's healthcare because of research, kind of like what Farzana was talking about. And a Danish study has talked about the fact that it takes women 4 years longer to be diagnosed with the same mental health problem that men can be diagnosed with, and 2 years longer for cancer diagnoses. So that's really scary. And then my biggest one that I really have some passion about has to do with Serena Williams and how she's a perfect spokesperson for women not being heard, and especially women of color not being heard. And the fact that we're not listening to somebody who probably knows her body better than 95% of the people in the world, and they weren't listening to her. So it's all wrapped up in that, and it is exciting for me. So thank you. And we can move forward with any questions people might have.
Yeah, so I actually have a few questions for you. And what I'm going to do is kind of interweave some of the questions that are being asked in the Q&A as well. But the very first thing I want to ask kind of goes off of what some of you were saying of this gender bias. So to take a step back here and explain what gender bias is first, gender bias is going to be that type of prejudice that favors one gender over another. So gender bias is something that you can experience outside of healthcare too, but we do see it quite frequently within the healthcare system, primarily impacting women and their experiences and the innate biases that some people come in with about women, right? So gender is going to be that it's based on how somebody identifies, while sex does refer to those biological characteristics. So we're talking gender in that format. And then because most cultures place a higher value on men and masculinity, gender bias tends to affect women and girls more severely, in addition to any individuals who people perceive as feminine, regardless of their gender. So in saying that, for my panelists, and you may answer in whichever way you see fit, or whichever order you see fit, but how does gender bias present in today's healthcare system? I know you had mentioned, Farzana, the white male patient being kind of the center of that research and experience. But how does gender bias kind of affect the care quality, the diagnoses, and overall healthcare outcomes for women?
Well, I'll just say that I just recently saw an article by the National Academies of Sciences, Engineering, and Medicine that underscored that fact that there remain issues of gender-based disparities in terms of access to care and affordability to care that is closely associated with income. So women still earn less than men, and that impacts their ability to access insurance, to provide nutritional food for their children, and actually also access to education, since educational attainment is correlated with healthcare. And I just want to, I don't want to dominate, I just want to say an interesting fact that was in that same article, and that is that there often are extraneous variables associated with gender that have been met, that have not been heard, which is ironically, given what Farzana said about how, the allopathic domain has been focused on the health of let's just say privileged men, right, in our society. Well, I was curious to see that the life expectancy of women, we already knew that that life expectancy is higher between women and men, but that is narrowing. So women are dying at an earlier age, but the extraneous variable, which is really interesting, is that white women, I'm a person of color, I'm Black, of mixed race person, but it was interesting for me to see that factor, that white women, the most recent research shows, I think it's between 2004 and 2014, are dying earlier. Why? Because of suicide, opioid use, and higher prevalence of chronic lung disease related to cigarette smoking. So it is interesting that when you peek behind the gender barriers that face women, we have to look at it in its totality, in my view. What do you think, Farzana, in that view, based on what you just said?
So actually,
about-
I think, oh no, thank you. So actually, I think it's very interesting that you brought up, it is a well understood fact that women on average tend to live longer than men. But one thing that they found out is that, yes, they do have extra years of life, but quality of life is decreased in comparison to men. So yes, they live longer, but the extra years they have aren't necessarily better. And
right, but this particular study said they're living, actually, just to be clear, that they are not living as long, even though women are living longer than men. Quantitatively, they're not living as long as men, and that must also incorporate factors like quality of life. I just wanted to be clear based on.
And I also wanted to jump back to something that Sandra said. So when she was talking about Serena Williams, who is like an amazing athlete, one of the best, most widely recognized athletes in the entire world, when she was pregnant, she had a pulmonary embolism. And Sandra can explain a little bit more what happened to Serena Williams when she had her pulmonary embolism in the hospital setting.
Yeah. Okay. I didn't know if you were going to say something else before, but
I didn't want to steal your thunder because I knew that this was something that you feel really passionate about.
Right. Exactly. Okay. And Serena Williams, in case, she's a tennis player and one of the best tennis players in the world. She had actually had a history of pulmonary embolism in the past. So she knew what it was like. And so she had an emergency C-section to deliver her baby. Everything went fine. But the next day she was in the hospital and started having shortness of breath. And she called the nurse and she told the nurse, I need to get a CAT scan because I think this is what it is. And and she actually she didn't want to scare her mother. So she walked out of her room. And this was in an interview that she did with Vogue, by the way. So, but she said she walked out of the room to talk to the nurse about it. And the nurse said that her medicine was probably causing her to feel uncomfortable. And that's what it was. And she said, no, I'm really short of breath. I need you to do this. Instead, they ordered a Doppler. So I don't know, a Doppler and something else. And of course, the Doppler came back negative. And so finally they did go ahead because her shortness of breath was obvious. And do the CAT scan and found indeed numerous bubbles in her lungs, and then it got worse and it took time, of course, over time. If they'd have caught it sooner, it may not have been as much of a problem. But afterwards, she then suffered more because she was coughing so much because of it. Her stitches split, and it turned out she had a hematoma in her uterus, I believe is where it was. So please correct me if I got any of the medical part wrong, Farzana. But so people would not listen to her, even when she knew what was going on and why it was happening. So, and that's indeed what happens the most. Black women suffer the most from having poor outcomes with either maternal outcomes or infant outcomes. The infant mortality for Black women is 11 per 10. I want to make sure I have this right. 11 per 1,000, and white and Latinx women, it's 5 in 1,000. So, and
wow.
Indigenous women, 8 in 1,000.
But what's interesting to me, Sandra, is that Serena Williams is an outlier, okay, because she's very wealthy. She's well known. She's like an Oprah. I mean, everybody knows her name. She has a brand. So what's interesting to me is that we don't know for sure. Okay, we know from her from the interview that she felt that somewhere she was discriminated against in that clinical environment, but it's Black and brown women who have lower income, who don't have the resources that a Serena has, that usually occurs. So I'm just curious to just follow through on that question. Do you believe that based on that interview, that is she articulating that she was facing bias, or that was her perception, or was it not clear?
Oh, yes, please.
Wait, I'm sorry. I just wanted to segue into this real quick because yes, this is something that's not unique to Serena Williams, but you do mention a good point that she herself, even as a woman of color, is in a position of privilege, being someone who is very wealthy. But one thing that I do want to mention is that pulmonary embolisms are not something unique to women. It occurs in men and women, and it is notorious for being difficult to diagnose because your main symptoms that you have when you have a pulmonary embolism are chest pain, shortness of breath, and a sense of impending doom. But what you notice is that when women have pulmonary embolisms, women across the board, doesn't matter their socioeconomic status, doesn't matter what race or ethnicity they are, but just the fact of being a woman means that they have delayed diagnoses, misdiagnoses, and thus worse overall outcomes in comparison to men. And this actually segues into heart attacks, because when you think about the big scary things, right? The big scary no misdiagnosis, you never want to miss these diagnoses if a patient comes into you. Heart attacks, strokes, pulmonary embolisms. There's other ones, but those are like the big ones. And what the interesting thing is, when you think about a patient who has a heart attack, what do you think of? You think of a patient that's coming to you saying, I have crushing chest pain. And maybe you think, oh yeah, okay, crushing chest pain that radiates to the left shoulder. And that is like the classic chest pain symptom. But you know what? That's the chest pain symptom that you see in men. And in women.
I just wanted to interrupt you for a second, because this is supposed to be about public health too. And I just wanted to just segue. I want to challenge you to just play the devil's advocate. You're talking about gender disparities and not so much about perceptions of discrimination. I just want to play a devil's advocate with respect to, actually, this happened to my late father, who was Black, and he actually, and so I want to know, to get everybody's understanding of how I think we have to not be limited in understanding how color and ethnic bias can impact healthcare outcomes. So in this case, he found out in 1990 that he had cancer, and he went to a hospital in Scottsdale. Sorry, it was in Phoenix, and they found out that that they diagnosed him with cancer. Guess what? They didn't know anything about him. All they knew that he was 6'5" tall Black guy. All right. They didn't know that he was on the board of General Motors. They didn't know, and they didn't really care. Okay. They sent him home to die. My mother believed that it was race. There was a factor of race. Fortunately, in our case, my mother called the president of General Motors, who put my father on a plane to go to Sloan Kettering, where he was diagnosed properly, and he lived another 13 years. That is the convergence between, prestige income versus, historical understanding and perception of race. So I'm wondering, back to gender, Farzana, how would you, from a clinical standpoint, how would you articulate that particular scenario where race definitely did impact my father's health? And if my mother had not intervened to access resources that she had based on prestige, what do you believe would have been the outcome? And do you think that there's any association between that and what you're talking about in terms of?
Just to be clear, absolutely, health plays an important impact on healthcare outcomes as well. And we see that as well. We see that people who are minorities, specifically non-Hispanic Black Americans, tend to have overall worse healthcare outcomes from not only heart attacks, but strokes and other all-cause mortality. So yes, absolutely, your race plays a huge part about what kind of healthcare quality services you receive. But even if you control for race, even if you remove race as a factor, women still receive worse quality healthcare compared to their male counterparts. And the reason why I was mentioning heart attacks is because only 21% of women get that crushing sensation as their symptom, and the other 80% don't. And so when you have a physician who's classically trained in medicine with the idea that the patient is going to be a male Caucasian patient, you're going to miss all of those cases where maybe it's not the chest pain, maybe it's the anxiety, maybe it's the sense of impending doom, maybe it's the sudden onset fatigue and shortness of breath. And the healthcare provider in that setting, not having the appropriate training, says, you know what? I don't think that this is an urgent scenario. I think you should follow up with your mental health care provider, which is concerning because then that patient gets a delayed diagnosis, misdiagnosis, and overall worse healthcare outcomes.
And do you believe that that is what occurred with Serena, Sandra, or sorry, Farzana?
You know what? Yeah, let's jump back to Sandra. Yeah, Sandra, tell us.
Well, it's the lack of belief in.
Wait, I'm taking Riley's role.
Honestly, you are doing a fabulous job, so I'm okay with it.
Well, what they talk about is indeed the fact that not believing, and that's one of the biggest issues that's going on. And it's an intersectional thing that women are believed less, and people of color are believed less, and in the LGBTQ people are believed less. You know, women are known to, you know, the whole everything related to the term hysterical and its roots of the word hysterectomy, and you know, in being similar, related to women are hysterical. They're not really sick. They're just hysterical. It's a mental issue. So, and I kind of want to swing back to what you said about what we can do related to people of all different levels, socioeconomic levels. And one of the issues I think that Serena Williams is just great for is the fact that she is happy to, yes, she's a person of privilege, but she is absolutely happy to serve as somebody who says, look at me, just like what we saw. Who was it that was in Back to the Future that has Parkinson's? I can't think of his name. Anyway, the idea that these people or Chris Reeves, who broke his neck and became a spokesperson for individuals with, oh yes, Michael J. Fox, thank you. Michael J. Fox, who is a spokesperson for people with Parkinson's, has shown what people can do and can help people get more help and help people recognize that there's more we should be doing. In this case, it's more we all should be doing, and the healthcare system should be doing more to recognize that we're not doing enough. But also, part of it is that we don't have enough women in leadership in healthcare, and that's something that we need to be working on too. And I hope programs like this, programs like what we have in our colleges here, can push that forward and say the more women we get in leadership roles, the more we can get people recognizing that we have to be looking at things from a lot of different angles.
Yeah. So actually talking about having women in leadership roles, when you look at the amount of healthcare providers, like just, I'm specifically talking about physicians. When you look at physicians in the United States and you classify them based on specialty and based on gender. In 2019 data, what you see is that there are almost 2 to 3 times more male physicians in almost every single specialty. The only exception being OBGYN medicine, dermatology, and pediatrics. And the big concern is that there are 20,000 male general surgeons and only 5,000 female general surgeons. And maybe it's like, oh, okay, that's not a big deal, but a recent super controversial and a little bit groundbreaking, crazy study was published just back in December of 2021. So it just came out a couple months ago. And this study, which has been making researchers argue like crazy, basically it took 1 million patients in Canada between 2007 to 2019, and it looked at healthcare outcomes post-op and it categorized them based on the gender of the physician, the surgeon, and the gender of the patient. And what they found was that when there's a lack of matching, a lack of concordance between the gender of the physician and the gender of the patient, specifically if you had a male surgeon and a female patient, there was a 7% mortality increase. And you didn't see that if the male surgeon was treating a male patient, and you didn't see that if the female surgeon was treating a male or female patient. So it's specifically unique to male surgeons with female patients. And we are seeing this pop up more and more in literature now, the idea of concordance, the idea that if your physician can't relate to their patient, if there's a significant cultural gap, age gap, gender gap, or a lack of shared experiences between the healthcare provider and the patient, that does lead to worse overall healthcare outcomes for the patient. So what I would recommend is we need to get rid of that, right? We need to get rid of that disconcordance and have healthcare providers that are more likely to empathize and understand their patients.
I would agree. I just wanted to follow on to that point. I'm working on a paper right now with faculty from Hungary, Czechia, Ethiopia, and someone from Edson on that issue of empathy. And we started off the discussion about what we need to do to actually move the ball forward and not stay stagnant in accepting every 10 years another healthy people, 2030, 2040, 2050, and seeing the same themes of barriers to access to care based on peer-reviewed studies like the ones that Farzana cited. And I think that the issue is that in the United States, one of the factors we need to address is why we are compliant with accepting issues like residential segregation. Why are we compliant with issues like non-access of homeless people, women and men, access to healthcare resources, or why the maternal mortality rate of Black women is so high that it makes our maternal mortality, the maternal mortality rate in the US, the outlier in comparison to the same rates of other Western industrialized countries. So I think that we need to do more work, more granular work in understanding how to incorporate empathy, as you said, Farzana. What does empathy look like? It could mean actually being trained into spending more time in a clinic or a public health setting or a community health setting with individuals who are vulnerable. And vulnerability could be the color of your skin. It could be whether you have a disability. It could be you're a refugee. But whatever those markers are, that triggers a response that enables that person to get more resources to them.
Yeah, and I do want to hop in here real quick, because Farzana, I know you have to step out soon, so feel free. She does have class to teach, which is totally fine. But in the sake of time here, we have about 5 to 10 minutes left. So I do want to get to some of the questions that we have in our queue, and kind of lead that into our closing question for you all, because even though I had some questions that were listed out, you definitely combine them all, because I think it's really easy to see that this is a topic and a concept and a problem that is widespread, very complex as well. So there's a lot of moving factors that are within women's health disparities and what we kind of see, which is why this is just an introduction to women's health disparities. So I really appreciate all that you had to say on this. But one of the questions that we have in our chat is, are we able to discuss transgender women's health and how their kind of experience is within the healthcare system, as well as ways that we can work to close some of those disparities? And in that question, I also want to add on our second part of that is moving forward in general. What can we do to kind of help close those disparities, work on addressing the barriers and some of the challenges that all women are facing too?
Okay, I am going to step out. So before I leave, I just want to toss in my last 2 cents before I run away. So transgender women are absolutely women. Transgender women are women, and their health is also incredibly important. And yet they have a similar gap, right? Like transgender women also have worse overall healthcare outcomes in comparison to almost all other health population groups. And a lot of that is due to discrimination. Unfortunately, I am by no means an expert in transgender medicine and understanding the nuances behind why these discriminations occur. So I don't feel comfortable trying to delve more into that because I don't know. I would have to do more research onto that. But one thing that I do want to jump in and say really quick before I run away is that I agree with Julie. I really agree with Julie because the concordance studies have been going on for the past couple of years. They're the kind of the new popular thing to figure out how can we optimize healthcare outcomes for people who we think may not be getting the best healthcare outcomes. And what they noticed is that if you have a person of color, and that person of color having a heart attack, male or gender, will have worse healthcare outcomes compared to white counterparts if their physician is white. If you have a person of color and their physician is Black, they have better healthcare outcomes. But if you have a person of color with a white physician who works with Black colleagues and is familiar with Black patients, better end mortality rates for their Black patients. So what we really need is exposure, understanding, and further education and training for all population groups that are not having the same healthcare outcomes than we see in our cookie cutter white male counterparts. And I'm going to run away now. So thank you
That's
so much
great.
for having me on this panel. Great. Bye, guys.
Yeah, thank you so much.
Great. Great. I just want to just follow on to what Farzana said. I think everything that she said was true about understanding concordance, but also understanding that implicit bias training is not sufficient, right? Because implicit bias, we all know that we have it, right? But that doesn't necessarily mean you're going to use the tools of the knowledge that you've gained in clinical settings. And that research has been shown to be true. What we don't do is understanding why there is a tacit acceptance in our country for some groups of people. We're okay with the poorest people amongst us to have less resources, whether it's residential segregation and living in food deserts, whether it's the 20 million that don't have health insurance. It reminds me very much of like the situation in Ukraine, where we're sitting here in our homes watching the horror on TV, like, okay, that's not us in the bomb shelter. Okay, so at the end of the day, that's not us. You know, so there has to be more passion behind identifying solutions.
And I just want to add to that. Exactly. The whole idea about access to care is one of the biggest things we need to be addressing more. And however we are going to look into doing that, we need to be pushing forward. And I do think we are doing a good job of doing an intro to that in our programs, but there's so much more that we need to do related to that. And for all kinds of issues, and that includes LGBTQ in populations, minority populations of any sort, even aging populations. Now, with the aging of society, what we are seeing is there's all kinds of things going on with gerontology. And in fact, we have some of that going on here, which is fabulous. But we have to recognize that there are other populations we need to be putting that kind of effort into also. So,
exactly, Sandra. And just to your point, I know we have to go, but the point about trans people who are trans, who are women, there is a body of data that demonstrates, and the paper, the NIH, CDC, the National Academies of Sciences, if you look and examine, there is this body of data that demonstrates that these are communities that are locked out of the system, and they are facing discrimination that's impacting their health. So that goes along with what you were saying. True. Really well said.
Yeah, and I do have one more question on here. So for our panelists, if attendees wanted to contact any of you, what is your preference? Either like LinkedIn, email. We can definitely send that out when we send out our resources document.
For me, email. I don't have a LinkedIn.
Okay, I could LinkedIn or email is fine with me. So I'm in LinkedIn also.
Okay.
So but yeah, I'm happy to talk with individuals related to that. Thank you.
Yeah.
I've really enjoyed doing this, Riley. Thank you so much for setting it up for us. I'm excited to see what we can see individuals move into to try and be doing something to make these issues, bring these issues to the forefront more, like Julie's talking about, and start making some changes that can actually show in the progress part of Healthy People 2030.
Right. Thank
Yeah.
you. I agree.
And I definitely love to frame these types of events that we're doing with the Health Disparities panels more as discussions, because that's what they end up being more so than a Q&A type panel. But I really do appreciate you all being here today. I think some great content was covered, and I would love to see this discussion continue on in different ways and within the students of our college. There are a few things that I would like to highlight for everybody who is here today. Just a reminder that this session has been recorded, so anyone who wasn't able to make it today or had to miss certain portions of today, it has been recorded, so you can go and visit the ASU Health Solutions YouTube page and find it there. We are also going to work on finding other means to get that out to students, or if you just had such a great time today and you want to share it with any of your peers or friends or colleagues, you are more than welcome to share that link as well. You can go ahead, QR code right there. That is also the short link to that page. And then I do want to highlight some upcoming college events that we have for both the College of Health Solutions and the Edson College of Nursing and Health Innovation. So for the College of Health Solutions, on Thursday, March 17th, there is going to be a Hanging with Helitzer town hall. And then Mercedes, I don't know if you want to speak more on that event for this specifically.
Actually, quick little update is Hanging with Helter has been canceled for this week.
No.
So if you saw any previous promotion, please disregard. We will move forward. However, if you have any questions, comments, or concerns, or would like a chance to talk to the dean, you are more than welcome to contact me at mercedes.amador@asu.edu, and I will include that in the chat.
Just kidding. So you can visit their Sendable Sync on for the College of Health Solutions to see other events that are upcoming. You can also scan that QR code there. And then for the Edson College of Nursing and Health Innovation, we have a few events that are coming up. The biggest ones we're going to have are going to be our Bike with the Dean event, which is a student and alumni networking opportunity. So the last day to RSVP for that is going to be March 25th. And then we have our Spring Student Staff and Faculty Party that is also networking and career prep focused, happening on April 7th. The last day to RSVP is going to be April 4th. So you can find out more about that by visiting our Sun Devil Sync page on OrgSync, and then also by scanning the QR code that is there. But to wrap things up, we really appreciate you all being here today, and I appreciate our amazing faculty who are here to discuss. I think there were some really great topics that were brought up and some concepts and points. And if you have anything that was referenced today that you would like to share out with our attendees, please send that my way and we can input that into our resources document for all of those folks to continue on their research and their learning. So thank you.
Thank you, Riley.